Hello, everyone. Good afternoon. My name is Jennifer Bell. I'm a senior bioethicist and clinician investigator at the University Health Network, where I primarily support the Princess Margaret Cancer Center. This lecture, the Philippa Harris Lecture on Bioethical Issues in Cancer Care and Research, is being co-presented by the UHN Department of Clinical and Organizational Ethics and the University of Toronto Joint Centre for Bioethics. On behalf of our teams, I'm delighted to extend a very warm welcome to you all today. This lecture is being recorded and will be archived on the Joint Center for Bioethics YouTube channel. If you are a UHN employee, you will also be able to access the archived lecture through our UHN Bioethics intranet site. So today we are celebrating the 42nd year of this engaging endowed lecture series that continues to be the highlight of our year. For over 40 years, this lecture has sparked engaged discussion within our hospital and community about ethical issues in cancer care as they relate to clinical care, research, and organizational ethics. This lectureship was established at Princess Margaret by Bill and Pat Harris to honor their daughter Pippa, who in 1981 died from cancer at the age of 20. One of the aims of this event, in addition to memorializing a remarkable young woman, is to serve as a catalyst for open and respectful dialogue within our community about timely and important ethical issues arising in healthcare. We have been fortunate to have been given the opportunity to host accomplished speakers presenting on a range of thought-provoking and timely topics. Last year, Dr. Christopher Latham spoke about inequities in cancer care experienced by those marginalized by race, class, and social determinants of health. Today's speaker, Dr. Oyedeji Ayonrinde, continues the conversation about equity in cancer care by discussing barriers to care for those living with severe mental illness. We thank Bill and Pat Harris and their family and friends for their great generosity. They've made the Philippa Harris Lecture on Bioethical Issues in Cancer Care a much anticipated annual event. The structure of our time together will be as follows. First, we will hear Mrs. Harris's remembrance of her daughter Pippa. This will be followed by Dr. Ayorinde's presentation, after which we will have a facilitated discussion moderated by our UHN Department of Clinical and Organizational Ethics colleague, Kevin Rodriguez. Please post your questions in the chat box for the discussion. And if you aren't logged into YouTube and want to send in a question anonymously, please send an email to terry@jcb.ea@utoronto.ca. The email will be posted in the chat, and we will post the Joint Center. We will post the email address to email in the chat. So we would like to begin by acknowledging this sacred land upon which the University Health Network operates. For thousands of years, it has been the traditional territory of the Huron-Wendat, the Haudenosaunee, and most recently, the Mississaugas of the Credit River. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Haudenosaunee Confederacy and the Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. Today, the meeting place of Toronto is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work and learn on this territory. We support ongoing work to challenge the legacies of colonialism and stand in solidarity with protests against racism and systemic discrimination, and endeavor to work with our UHN colleagues and leaders to support efforts to advance equity, diversity, and inclusion. We will now play a video that Mrs. Harris pre-recorded with the assistance of her daughter, Pippa's sister, Diana.
I am Pat Harris, the mother of Philippa. We called her Pippa. For 42 years, it has been my pleasure to talk briefly about Pippa before this lecture. Pippa loved animals and was kind and brave. She had talent to create amusing art and warm friendships. Her closest friends are still part of our family, and many of them are here in our audience today. This is my last year to speak. It's like I'm getting older. In the future, Pippa's siblings will have this honor. That's my wish. Our family would like to thank Dr. Ayonrinde for agreeing to be this year's lecturer. May I say thank you, Dr. Deji.
Thank you, Pat. These are very moving reflections and a joyful memory of Pippa, and we look forward. It's a great prelude to Dr. Deji's presentation. So now it gives me great pleasure to formally introduce our speaker. Dr. Deji Ayonrinde earned his Bachelor of Medicine and Bachelor of Surgery from University College Hospital in Ibadan, Nigeria, and residency training in psychiatry at the Bethlehem Royal and Maudsley Hospitals in London. He earned a Master's in Psychiatric Theory and Research at the University of London, a Diploma in History of Medicine from the Society of Apothecaries, and an Executive MBA from Imperial College London. He is a Fellow of the Royal College of Psychiatrists and an International Fellow of the American Psychiatric Association. While living in the UK, Dr. Ayonrinde worked for the South London and Maudsley NHS Foundation Trust, where he served in several capacities. Since moving to Canada, Dr. Ayonrinde served as the medical director for the Early Psychosis Intervention Program and is now the clinical director for community mental programs with Providence Care. He currently works for Queen's with cross-departmental appointments as an associate professor in both the departments of psychiatry and psychology, where he serves as a preceptor for the master's and residency programs. Dr. Ayonrinde has acted in consultation, training, and advisory roles for clinicians and clinical services in Australia, China, Malta, Nigeria, and the United States. He served as a cannabis awareness expert for Health Canada, a cannabis awareness trainer for the Canadian Armed Forces, and in curriculum and content development with the World Psychiatric Association. He has also established close working relationships with a number of marginalized Indigenous populations globally. Dr. Ayonrinde is committed to health equity, global health, community and youth initiatives, including cancer, homelessness, visible minorities, and Indigenous health, and is working with colleagues to develop recognition of street psychiatry. Throughout his career as a researcher, educator, and clinician, Dr. Ayonrinde has been the recipient of several honors and awards. He is a recipient of the Psychiatric Hospital Yaba Award for Innovative Contribution to Patient Life, the Imperial College Business School Joan Woodward Prize for Research and Organizational Behavior, and 3 Clinical Excellence Awards from the United Kingdom. In Canada, Dr. Ayonrinde has been recognized with the Partners in Research Biomedical Ambassador Award, the Kingston Health Sciences Center for Knowledge Translation Initiatives regarding Cannabis Knowledge Award, and the Queen's University Faculty of Health Sciences Recognition for Cannabis Initiatives Award. Without further ado, I would now like to welcome Dr. Ayonrinde to present.
Thank you so much, Jennifer, and I'd like to express my greatest appreciation to Mrs. Harris. I really wish I could have hugged you through Zoom. Thank you so much. You spoke so beautifully about Pippa, and you were glowing in your own beauty too. Now I'll share the screen. I hope you can see my screen. Thank you. So I speak to you today from the traditional and indigenous land of the Anishinaabe and the Haudenosaunee in Kingston, Ontario, Canada. I'll be speaking about cancer and severe mental illness, navigating the syndemic challenges, and would like to use today to provoke our thinking around a number of things. So our objectives will be the concept of evidence, equity, and ethics. Evidence as in, whose evidence do we use in our decision making, and are some people left out of research, therefore further inequity through the process of evidence? The challenges of ethics in our day-to-day practice and the moral distress this may cause, and the syndemic challenge of the populations we serve in our different fields. Our objectives will be to highlight cancer morbidity and mortality and severe mental illness, to increase awareness of challenges experienced by people with severe mental illness with cancer care, and a call for collaborative, interdisciplinary, and intersectoral action. We all have a role to play. Conflicts of interest. I have no financial conflicts of interest. I do have lived experience as a caregiver. both to my late mother, who died of cancer, and also my youngest brother, who died of cancer, a cancer-related illness also, both within the last 6 years. I would also like to honor friends who've lived with cancer and patients I continue to serve daily with cancer as well, either lived with or were deceased with cancer. I'd also like to acknowledge all the millions of people with mental illness and mental disorders who struggle day to day at a time of uncertainty in the world. So just a few reflection points. Mental health is a human right, and we all have a right to receiving the best mental health care we can, not necessarily from formal psychiatric services. It could be the kindness and compassion of a neighbor, a friend, someone in the workplace, but it is a human right. And yet very few people know their full rights with mental health care. How many people know they do have a right to participate in treatment, a right to be treated with dignity, a right to have a say? A right to have access to quality mental health, and recognize the stigma, which is all too common, should not hold people back from the mental health care they deserve to receive. 1 in 8 people live with a mental health condition, and on the balance of probability, several of us would be living with a mental health condition. It's safe to say no one, absolutely no one, enjoys 100% mental health 100% of the time. So this is a huge population of all of us who may be dealing with challenges at one time or another, or a loved one dealing with mental health issues. We also know that a lot of people live with chronic diseases. Many smoke, many drink alcohol. Not everyone has opportunities to have fresh vegetables. In fact, they're more expensive. A lot of people are inactive, and the pandemic has further destabilized these numbers. And this has a huge impact on the general wellness of so many people in populations all over the world. And when we look at health inequities, we cannot understate or overstate just the sheer burden the health inequities can cause. So nearly 2.5 times more deaths for people with diabetes, nearly over 2 times more chronic lower respiratory disease, nearly 2 or 1.5 to 2 times more cardiovascular disease and death from cancer compared to the general population. So health inequities, the right column, really worsen quality of life, life expectancy, and the sheer burden on individuals, their loved ones, and services. So if we choose an example like smoking, and these cigarettes are not to proportion, but if you look at SMI, as in severe mental illness, which I'll explain a bit more, the general population, Ontario, and those with a severe mental illness, within our service, for instance, over 60% of individuals with severe mental illness smoke. Now, this is a huge problem, but also presents opportunities for intervention. So what do we refer to as severe mental illness? We're talking about mental illness often enduring, long-lasting, but may have considerable impact on individuals' well-being. Disorders like schizophrenia, bipolar disorder, schizoaffective disorder, and some people living with traumatic brain injury. By schizophrenia, we refer to a mental disorder characterized quite often, not always, by the experience of hallucinations. These could be abnormal sensations or experiences in any of the 5 senses. A person may also experience delusions, fixed, firmly held belief systems that aren't in keeping with the culture or their educational level. Bipolar disorder, a mood disorder characterized by periods of elevated mood, or as called mania, or depressed mood, depression, and schizoaffective disorder, a sort of hybrid of that. So these are individuals within our populations, many within our individual families living with severe mental illness. And we look at common cancers. This is by no means an exhaustive list. breast cancer, colorectal cancer, lung cancer, cervical, and prostate cancer. And yet no one has full protection with a severe mental illness from also having cancer. So anyone can have cancer. So that takes us into syndemics. And syndemic, the word syndemic was in the title. So a syndemic is a sort of synergistic epidemic involving the clustering of two or more diseases within a population, the biological, social, and psychological interaction of the diseases, and the large-scale social forces that precipitate disease cluster in the first place. So by syndemics, in this case, we're referring to the collision of severe mental illness with cancer, or the collision of cancer with severe mental illness, and the sort of amplified effect it may have on an individual. This slide just has a few examples of syndemics, and we could spend an hour on it, which we won't, but you can see, if you look at syndemic combinations of mental health issues and HIV, or mental health issues and poverty, or racism, and so on, and a multitude of variations. So these are examples of syndemics. And for today, we're focusing on severe mental illness and cancer. Now, also often we hear terms like equity, diversity, inclusion, indigeneity, accessibility, EDI, EDIIA, some would add a J for justice, and so on. And I would argue and put across to you that the populations we're talking about are not equity seeking. If we use that term in our day-to-day work with this population, it's worth correcting and redressing, because many of the population don't know to seek equity. They don't understand their rights. They may be so vulnerable, so ill, that they don't actually seek equity. But their equity deserving, meaning it's incumbent on us to ensure they receive the equity they deserve. So within severe mental illness, we have higher rates of smoking, COPD, obesity, type 2 diabetes, heart disease, metabolic syndrome, substance misuse. And within populations of severe mental illness, 20 to 25 years shorter life expectancy than their age-matched peers. I'll refer to that several times over, because this is a population that doesn't have the same longevity as the people they were born on the same day with, and share birthdays with. Severe mental illness populations experience more homelessness than the general population. And this understandable accommodation and residential facilities, living facilities are quite limited at the moment. That's day-to-day news. But even people who have employment, secure employment. So those who don't have secure employment are unable to pay a rent or own a home, may also misuse substances, are more vulnerable. And there's an excess of individuals with severe mental illness who are homeless within our communities. Substance misuse, crystal meth, cocaine, cannabis, harmfully used, and a whole range of other substances have higher rates also within populations with severe mental illness, including opioids. And how does this then, the severe mental illness, overlap with cancer care journeys? We'll explore prevention, and given the lifestyle, the dietary, the vulnerability experience with a whole range of other syndemic health conditions, prevention, including smoking, is not as good in these populations. How well do individuals with severe mental illness screen? Breast cancer, pap smears, fit tests, and so on. And how well and what time do we commit to making an appropriate diagnosis or provide them treatment? And how well do they engage or continue with treatment for cancer? And as the journey continues, what's the recovery like? What's their survivorship? End of life care, to mention a few. Now we have all these fairly sophisticated pathway map legends. Some of you may have actually contributed to designing these. And the interdisciplinarity and the complexity of specialist services within oncology is really striking in large centers. Yet, how does a person with severe mental illness navigate this? Likewise, the opposite end for people with severe mental illness, a number do receive their care through assertive community treatment teams. And these are specialist services that support people live in the community any which way to ensure they receive the best mental health care they can without being in a hospital. Many of these services provide care 365 days a year with nurses, OT, social work, concurrent disorder workers, psychologists, case managers, admin staff, psychiatrists in an interdisciplinary team. Some actually receive their medication daily at home from team members as well. Take-home points. Mortality risk in individuals with severe mental illness, for instance, schizophrenia, is about 2.5 times the general population. So for every 2 people in the general population with cancer, 5 with a severe mental illness will die. That is an equity issue. And perhaps if you watch this sometime later, but you can see some examples: breast cancer, lung cancer, colon cancer, and also there are differences between men and women. But this is a striking point, 2.5 times the general population. And we look at this presentation by Erwin and colleagues, also a whole range of systemic and structural issues come to play. The system, the health system, whether it's fragmented or not, do people get to screen? Are there delays in waiting lists? Do you have a family doctor or not? The patient factors regarding the severity of their illness, comorbid health conditions, and so on. The health providers, whether they exist or not. Cancer care, prevention, diagnosis, treatment, as I mentioned, and the quality of life survival. So every time we say there's a shortage of family physicians, that impacts this sort of journey. Every time there's a long waiting list for psychiatric care, that impacts this journey. Every time cancer care becomes more sophisticated and more digital, that impacts this journey, and I'll illustrate. So cancer prevention, we can target smoking, and that's one of the commoner areas, but how many services actually have developed smoking cessation services and interventions with training? Very few do, and I'll make reference to a report at the end of the presentation. Cognitive symptoms. The better people are cognitively, the better they can engage with services. But can this be assured? Not always. Positive symptoms. So positive symptoms in severe mental illness will be the hallucinations, the delusions, and so on, and the way they may impact the journey. Or the what we call negative symptoms, just the lack of motivation and drive. How does this overlap with appointment scheduling? And how do you schedule an appointment for someone who's homeless, or who may have unstable accommodation, or never opens their post, may not even have a phone? And stigma. Sadly, cancer comes with a lot of stigma, and so does severe mental illness. People get blamed for their health and lifestyle. If I'm overweight, I'm blamed for not being fit and lean. People are scared and worry whether people with severe mental illness are going to be violent. Oh my God, I'm not sure we should see him in clinic. What if he hurts us? Self-stigma and loss of self-esteem. Diagnostic overshadowing. And that's a situation where a person with severe mental illness, let's say schizophrenia, goes to the emergency department, complains of abdominal pain or noticing bleeding, and what people see is the diagnosis of schizophrenia and don't consider other health conditions, for instance, cancer that may be occurring. And assumptions also being made about decision-making capability. So from a stigma point of view, to a hammer, particularly diagnostic overshadowing, to a hammer, everything looks like a nail. Now, Ontario Cancer Care has amazing resources online for breast cancer, kidney cancer, and it's a really interesting My Cancer IQ website. You can sort of actually engage your risk and be informed. However, if we look at our community programs, 86% of people we serve in our community mental health population with severe mental illness have no independent internet or video conferencing capability. 86%. So this amazing resource, unfortunately, leaves some of the folks behind. We'll have a few case studies to sort of give you insights into this world, looking at colorectal cancer, cervical cancer, breast, lung, and prostate cancer. Colorectal cancer. And these are adaptations of real situations. My ex punched me in the tummy 6 times. I knew it was going to damage my insides. And that's why I ended up with colorectal cancer, because I was hit in the tummy. I knew they were trying to poison me. I couldn't stop pooping. And that was someone's interpretation of bowel prep. I did very well. I only had 1 donut that morning before going for the colonoscopy, and the person was denied colonoscopy. The fit test instructions, these are really helpful if you've got the attention and concentration to go through the whole process. But some people I serve struggle. The instructions are sequenced over 42 lines. 42 lines that need attention and concentration to follow through. With a fit test also, these sequences are fold in and so on. You need to be able to follow step by step. Many of the clients I serve struggle with this fairly simple test. Where did they put a sample? Oh, doctor, there's no way I'm going to put poop in the post. That's dirty, doctor. Oh, well, I put it in the fridge, but I didn't know what to do. I kept trying to poop, but too much poop came out and so on. Or some of the message and information available for sigmoidoscopy or colonoscopy. And it's there, well written out. During the test, the doctor or nurse will apply a flexible tube with a tiny camera on the end to look inside the rectum and sigmoid colon. Doctor, they put a camera in me. Those people put a camera in me and they're watching me and they're broadcasting it over the internet. Or colonoscopy allows a doctor to look at the entire colon using a long flexible tube with a tiny camera on the end. If I'm paranoid and I'm psychotic and I'm not trusting people, the concept of a camera inside me may be scary, countertherapeutic, or make me very suspicious. Bowel prep. Amazing guidelines, but does that work well for everyone? And maybe bowel prep, if I'm going to do my bowel prep, perhaps it's better when I have someone around to support me through it. Maybe I should do my bowel prep starting on a Monday rather than a Saturday, and so on. And this can be, albeit simple for many, problematic for many as well. We had a campaign of Getting Fit in March to try and support people doing their fit test in the month of March. And we learned many lessons. It was nowhere near as easy as we thought. Some people just wouldn't follow. A particular person felt the test was a way of monitoring and that they were going to get DNA from it to research him and his functioning and so on. And these are the vulnerabilities that can occur. But how do we come up with innovative campaigns to support individuals? Cervical cancer. My neighbor has sex with me when I'm asleep and stains my underwear. That's why I have blood. And this person blamed the neighbor and kept on getting more and more locks on their door. I don't have sex, so I don't need screening. Why would I? It's only for people who have sex. I don't have sex, so there's no way I could have cervical cancer. The doctors tried to put something inside me to make me pregnant. There's no way I was going to have it. There's no way. I'm not going to let them put that thing in me and make me pregnant. And there's so many people living with trauma. A speculum and the whole process could be really frightening for those with post-traumatic stress disorder as well. Breast cancer. Breast examination may be easy for some people, but understanding the quadrants and how to check and so on isn't easy for everyone, and we should remain aware about how complex and difficult this may be for many individuals. Or the language we use in some situations. For instance, when it's said that, there was a suspicious breast mass or lesion. Now, suspicious when I'm paranoid and someone says that would even make me more scared, particularly if I'm living with severe mental illness. Lung cancer. This particular individual said, for instance, smoking stops my lungs from getting infections. So I smoke to try and get rid of infections because, doctor, when you smoke fish and smoke meat, it can keep for longer. So I want my lungs to keep for longer. Or the difficulties with smoking cessation. How does the person give account of cough or COPD or the weight loss? And are they able to give that account? Or is it weight loss or poor dietary intake? Prostate cancer. No way. There was no way I was going to let anyone put a finger in my bum. Pervert, referring to the doctor. And what happens when a person is unable to do a digital rectal exam or be sufficiently aware of lower urinary tract symptoms? So day-to-day instruments and tools used in cancer care, whether for colonoscopy, the speculum, mammograms and chest x-rays and so on, may pose very different for individuals with severe mental illness. Having had the pleasure of being in an MRI machine, I've heard from so many clients and patients I work with and serve that when they're in those machines, it's scary and it makes some clunky sound, and sometimes the machines talk into them and they incorporate it into an illness. It can be extremely scary. And are we being sufficiently patient and tolerant to these people, individuals like us, who may be struggling with screening or investigations? Pharmacotherapies, cancer care comes with side effects, but so does psychiatric treatment and antipsychotic medication, antidepressants as well. So what do we do when cancer medication and psychiatric medication have their own synergies? What do we do when something needs to be stopped or the combination needs to be changed? Or medication like clozapine, which is a gold standard for treatment-resistant psychosis that can have influence on blood counts, particularly white blood cell counts. And how do we balance these? Do we involve specialist pharmacists who understand psychiatric medication and oncology care? And what careful detail are we giving? Treatments. Receiving treatments at the best of times is no fun. Receiving treatments, if you have a severe mental illness, you're feeling agitated, you can't keep still, you're being asked to sit or be comfortable for a few hours, may be very difficult. If I'm receiving treatment and I'm hearing voices saying, that's cyanide, they're trying to kill you, you're just being poisoned, get out and leave, they're about to poison you today. How do I stay? I might just say, I'm not having this, I'm leaving. What if I have concurrent ADHD or other difficulties? How do I stay through the treatment? The frequency. Pump on, pump off. Am I comfortable having something in my neck or in my arm? Who are these people? What are they doing to me? Now, I'm using extreme examples, but they may not be extreme when people are very ill. Surgery. Preparation for surgery. Are we able to take part? Are we able to consent? Post-op rehab. There's substantial evidence that people with severe mental illness have far worse surgical outcomes with cancer care. Side effects. Side effects of chemotherapy, side effects of antipsychotic medication. How well has this been tolerated? Even in the fittest, well-prepared people, side effects from cancer care can be very difficult. Not talk about people who may be struggling with other aspects of their health, tolerability, hair loss, the neuropathies, and a whole range of other experiences, the nausea, the vomiting. And of course, ethical issues. We could have a whole workshop on this, but we won't today. Maybe we will during the Canadian Psychiatric Association conference in a few days' time. Well, not maybe, we will. But consent. Am I in a position to make informed consent? And how informed am I? And is the material provided to me and the way it's been explained sufficient for me to consent? What about the substitute decision maker? Even if they say, okay, yes, that substitute decision maker giving consent, can't make me have surgery, can't make me have a colonoscopy or a cervical smear. What happens when I refuse screening? I have a right to refuse a procedure. I have a right to refuse surgery, treatments, and palliative options. Is this driven by my illness or my lack of understanding or a whole range of other health inequities? And these are huge ethical syndemic issues. Recovery and remission. And who recovers? Very sadly, with many of these populations we serve with severe mental illness in cancer care, it comes down to the moral distress sometimes and the difficulty of the individual receiving cancer care, to a point that sometimes we have to ask ourselves, who do we let die? Who do we leave behind and why? Who and why? I remember someone I was working with who was homeless, living in a tent, stage 4 cancer, and would never go into a setting with unfamiliar people, would rather live in tent city with familiar people with stage 4 cancer, and sadly died in a tent. Or another person in the homeless shelter I sometimes volunteer in, who at 2 a.m. in the morning, in agony and pain, would leave the shelter and go into the woods to scream and yell in pain so as not to wake other people up. Syndemic cancer care with severe mental illness for palliative care. What are the processes? Is the person okay in a hospice? Are the people providing the care there experienced enough? Everyone deserves a dignified death. Are they able to have a dignified death and support with loved ones around like each of us deserves? And the funeral. Do they have a dignified funeral? Have you ever reflected on why so many funeral brochures of people with severe mental illness have pictures of them when they were much younger? Pause for a minute and reflect on that. One of the reasons is possibly because they don't have smart pictures of themselves in their 40s and 50s in a suit. And the pictures before that they use are pictures before they became ill. And for some people had poor self-care and so on. So there's a project we're involved with, and I'm aware of many other projects around the country, cancer and severe mental illness. A critical systems approach. And what I put across to you is to work in this space, it's an intersectoral, interdisciplinary systems thinking paradigm where problem solvers, anyone from any background, problem solvers aim to intervene in order to improve problematic social situations. And I would invite everyone to join us on our journey towards providing better care for people with severe mental illness through cancer care. Through health information and literacy, but not just any health information, but equitable health information. Has it been translated? Is the wording right? Do we take the time to help the person understand? Or do we just present what we give everyone? I would argue that if every single person receives exactly the same information the same way, with equality, you're not delivering equity. Because equity is making the reasonable adjustments to make sure each person has a fair access. And equity is the work we do to achieve equality. Equity is not an end point, it's a process towards achieving equality. I refer to this document beyond the scope of time today, but this is a really interesting document prepared and advisory work by Dr. Peter Selby, known to many of you and a few other colleagues, looked at Prevention System Quality Index, a special report on cancer prevention for people living with severe mental illness. It's less than a year old, worth reading. And it highlights the dearth, the absence or dearth of smoking cessation services for people with severe mental illness. Ontario Health has guidance on cancer, physical health interventions in hospital and the community, and smoking cessation is a primary target in this space. So today is an additional, I'm sure I'm not the first, but an additional call to action for problem solving and personalized collaborative care for people with severe mental illness in their journey through cancer care. I'd like to acknowledge clients and caregivers, experts by lived, living, and deceased knowledge. We owe so much to so many people living with challenges with as much dignity as they can. And it's incumbent on us that when people are their most vulnerable, we don't rob them of their dignity, but we support them. I'd like to thank research assistants, Sarah Mohammed, Jenna Nancy, Dr. Alex Rowe, who worked with me in the past, now in Toronto. And Alex, the kindest of psychiatrists, would accompany some of our clients for their oncology appointments and home visits and advocate. Dr. Jeremy Butler, an ethicist, may be known to some of you. Prof. Scott Berry, Scott's previously in Kingston, oncologist, ethicist, has been so kind in some of the conversations we've had on very complex cases and the understanding of the need for this sort of work. Christine Chiazza, smoking cessation coordinator, who continues to educate many of us here on smoking cessation and the importance of this in the work we do. Dr. Alison Maher, who's an epidemiologist and has done amazing work with her PhD and other work regarding equity seeking cancer care. Equity deserving, I stand corrected, equity deserving cancer care for those with severe mental illness. Kristen McCulloch, concurrent disorder specialist, who's been working with training nurses and nurse students in also being supporting people with severe mental illness in lung cancer screening and developing pathways. Our community teams, integrated care hub staff working with homelessness, and other collaborators. Finally, I'd like to thank Philippa Harris family for their kind work. It's 42 years of generous support to ethics, cancer, knowledge, and our understanding, encouraging us to be and bring the best of our humanity in what we do. UHN, Clinical Organizational Ethics Team, for sitting with us as we deal with very complex situations, the moral distress we deal with, and the decisions as we struggle day to day in trying to support people in their times of need. And thanking all those involved in cancer care and mental health support, with an appreciation that the majority of people involved in cancer care and mental health support are not qualified health professionals. They're mothers, brothers, fathers, sisters, friends who care deeply about another person in our communities and families. Thank you very much. I'll stop sharing.
Thank you very much for that talk, Dr. Ayonrinde. So I will be moderating our question and answer period for today. And you're so generous that you've given us a lot of time. I think that there will be a lot of questions that people will have. But given that I'm moderating this, I get first crack at it to give other people a chance to write their questions in. So as we await those, I do have a question for you. First of all, I really love shifting from equity seeking to equity deserving. And I guess this question goes along the lines of an equity deserving group. I'm thinking about, in particular, the case that you relayed around cervical cancer, but cases like that where we're looking at patients that need to undergo a screening or a diagnostic investigation, where they have a real barrier. So there's real harm or trauma that they face that presents a barrier from them, easily navigating that. And I'm wondering what your thoughts are on how that actually influences decision making and the limited alternatives that we seem to have or seem to be able to think about. So there's this sort of dichotomy that it's either we think of forced treatment, which would be horrible, or we're looking at something like palliation because we do respect that someone might be severely harmed if they were to undergo something that they could not fathom undergoing. So, I guess the question is, what are your thoughts on what the middle ground might be like? What does advocacy in this space look like? And I guess, how does one bring equity into these kinds of real cases?
Well, thank you so much, Kevin. I would say coercive interventions should not be considered as the first line of action. You don't want to restrain someone or medicate someone against their will to carry out an investigation. And sometimes it really invites us to be patient, persistent, tolerant, give the time. I'll use an illustration. We were working with an anonymous person, and it may not have been in Canada, so I'm not giving away any identity, who refused cervical smears for 15 years. And every time was offered, would refuse or would attend, and then get so scared and leave the room and scream and a lot of people gave up on this person. And it was a very kind nurse that spent time with this person to understand why. This person was living with trauma. And every time this was getting close to that, the person was having flashbacks. And a lot of work was done around the trauma and support, and extra time with planning, including meeting with the person who's going to carry out the procedure. And the person eventually did it. So that was a lengthy process. It took several months to achieve that. But there's another person who, and as ethicists, you can debate the ethics of this. This person had always wanted to dress as a witch for Halloween. And what the person working with this person negotiated was, okay, why don't you, after you had your mammogram and you've done your cervical smear, then maybe we can go to the shops and buy a whole witch's costume. And the person was so excited about that the desire to wear the witch's costume facilitated that process. Now, how much consent that was, whether it was coercive or not, we can debate that. But it's not easy. And I'd say on a case-by-case basis, I've taken to wherever I can, writing or thanking people who work in oncology services for giving time to our clients. And where possible, if we know someone's got an appointment, to request additional time. We try and encourage people to go accompanied and see if we can have someone accompany them for those appointments. Because even in the absence of a severe mental illness, having someone break the news about a diagnosis of cancer would be quite a shock. And over and over you ask people, so what did they say? I don't know, all I heard was blah, 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 a cancer. Or they say I'm number 4. And so what do you mean by number 4? He kept saying 4. What do you mean stage 4? I don't know. So this tests our humanity. And I would say for equity deserving populations, and I've not even used other examples like people with learning impairment and so on. As a society, do we just cut loose and move on? No, we must not. And we need to start innovating into these spaces now. So think of very creative, kind ways of supporting them, as we would for children, as we would for seniors in our communities. Long answer to a complex question.
Thank you. I appreciate that, though. And I think, bringing creativity into spaces of complexity is what we really need to be in the business of doing. So I've got another question here. It's asking for comment on cases where the team feels great moral distress. So where patients may have fluctuating mental illness with fluctuating capacity, no insight into their mental illness. And so situations where those patients might be refusing care or requiring care that the team can't provide. Do you have any thoughts around how to work with patients like that? And how do we know that where we've done enough? How do we know what we could do differently? So a similar themed question.
These sort of situations are more common than we think. These are situations that have clinicians in tears. The moral distress is huge. And for many people, they don't want to give up hope. They want to persist and keep trying and trying. And I'll say in our practice, I've come to value the role of an ethicist in these sort of situations, and developing supportive ethical frameworks, case conferences as well. Because there are some situations with your best of intent, knowing that what you could do may not be so difficult to do to help, but you can't. And that moral distress is so important that we discuss. When people are going through moral distress, that we don't set up a system that's not psychologically safe or start blaming people for mistakes and so on, but really appreciate that the compassion that we even need to show ourselves in these situations is so key. So I would say in the space of working with cancer and severe mental illness, we're going to assemble the whole team of players, the direct clinicians in oncology, direct clinicians in primary care, in community mental health and mental health programs. Ethicists often have a role as well. And I'm not saying that just because of this platform. We found that very helpful. It's a physician wellness issue. It's a health professional wellness issue as well. And we need to continue developing it further. I would strongly suggest that these sort of cases are built with vignettes. So we have, for instance, a collection of vignettes that we use for training and teaching, that these sort of complex situations are brought early into our training careers as an opportunity to actually collaboratively learn from different specialties as well. And ethicists, oncologists, psychiatrists, primary care, the whole range of skills in patient care. And sometimes, all too often we forget, there may also be important roles for pastoral interventions, spirituality services within the health system. And I've seen several situations where it's actually the chaplain spending time with someone in prayer or through support that helps them with their decision. But no one has a monopoly over this space. And yeah.
Thank you for that. So I'll go, we've got a few more here and they seem to be coming in as well. So this question, it's asking if there's better engagement on information sharing and consent conversations. So really looking at, are there any good tools or resources that we should be able, or that you could suggest accessing around information sharing with patients or consent conversations?
Yes, there are a number of projects, and we have a few at our end. I'm aware some colleagues in other places have as well, actually looking at the care pathways and looking at each of the stages. Some people are working, and I have someone working with me who's actually developing something that's more pictorial, that's got discussion points along the way for family and the individual, and so on, looking at the vocabulary being used as well, and also developing red flag terms that may not help. So these are terms to use with caution or not to avoid using, like suspicious and so on. Some of this can also be built into simulation exercises to help us better understand. And we've had a number of fairly engaging role play scenarios where people who thought it was easy realize, oh my God, so if, for instance, if you offered me, I said, but you're just trying to poison me. No, I'm not, but why is it going to my veins? Why am I losing my hair if it's not a poison? And the caregiver or professional may say, well, it's just targeting, trying to kill the cells. But that's why I said, you're trying to kill cells in my body. Why try to kill cells in my body? You're killing me. I told you you're killing me. I'm losing weight. I'm losing my hair. I'm throwing up. And then you say you're not trying to kill me. I'm out. And we need to develop ways of this. And I would say in the broader range of healthcare education, we have a lot we can learn from those in the humanities. Don't waste the people who are very experienced with simulation. whether it's digital simulation or performing arts and so on, in helping us test these scenarios and get better and better.
Thank you. So the next question, first of all, thanks you for a thoughtful lecture. And it says, in our healthcare system, many individuals need someone to advocate for them. Often family members or friends assume that role. Given how under-resourced mental health is, are there individuals in our midst who can take on that role? So maybe like a navigator kind of thing they're thinking. Do you have any thoughts on that?
That'll be wonderful. I mean, I can speak with lived experience. Supporting cancer care of a loved one is heavy. And you're trying to support your loved one, give of yourself, trying to advocate, trying to be present and strong while dealing with uncomfortable realities. There might be children and so on involved. And sometimes I'd say for many people with cancer, it's the whole family and the circle around them that's carrying the burden. And if there are opportunities for navigators, and I think it's an excellent question, an opportunity to start scaling up navigators. Navigators don't need complex degrees and qualifications. People just take people's support through the points, sit in with appointments, help take notes, maybe prepare the questions before the appointment so that the consent process can go more clearly, support with questions, and so on. Fantastic questions. I think I think if we have a spin-off outcome from today, it'll be strongly advocating the role of navigators for this population. Thank you.
Yeah, I agree. And the next one is another equity-themed question. So it's asking, we are increasingly reliant on virtual care, but you mentioned the number of patients without easy access to the internet or private ways to access virtual care. Do you have any thoughts about enhancing access? So they asked a question then about, do libraries or shelters have a role here?
Fantastic question. All the questions have been fantastic, but that's a really good question. The pandemic was an opportunity for us to actually test that out. So 86% of our patients didn't have internet access. They didn't have those sort of resources. And we thought, okay, what we could do is provide them the technology. So if everyone got an iPad or a digital device that could enhance this, that will sort it out. A good proportion had never used a digital device. We take swiping and things like that for granted. Many couldn't. Many couldn't hold a password in that whole process. A number were dealing with misinformation and thought, you've given me a phone as a monitoring device. Now you're spying on me with this phone. I'm not having it. Some thought it was causing 5G and making them more ill and so on. So on its own, it's not a full solution. It'll work with some people. Some shelters, like one of our local shelter here, actually has free Wi-Fi. And that's been an amazing resource for people there, some of whom have devices and can log in and access information. We mentioned the navigator earlier, and it might just be a wonderful role where with a patient's navigator with appropriately designed information can then go through some of those tests, like the cancer IQ information. So I would say this is all open space to innovation and creativity, business schools included, to innovate in these spaces. So different populations, the material may be all in English, and it can be fantastic information just in a language the person can't engage with. And if they can't engage with the material, it's a problem.
Thank you. So another challenging one here. It's asking if you could speak to the desire of MAID for patients in this population. So medical assistance in dying, where someone has mental illness as well as cancer, and it's difficult to differentiate between their mental illness, how that's impacting capacity. So whether or not they're making capable choices. So some really challenging cases.
That's an incredibly difficult question. Mental illness and mental disorders would be a whole spectrum, and a number of people have intractable, persistent mental disorders with limited recovery. Some people doubt their capacity to recover and make good functional recovery. Some people in the thick of the illness episode lose hope, and with support, they get a lot better. And I would say the training and expertise required to support people with mental illness, including severe depression and other mental disorders, to evaluate their capacity and their decision-making when they're considering MAID and going through the process needs considerable training. I would personally suggest it's done with second opinion structures, and it's not a solo activity. That we're very careful about the variables that may come into the mix, the variables related to the inequity that may be causing hopelessness. Is it resourcing? Am I living in a place where I don't have access to the range of treatments that other people may have access to? I mean, there's some centers that have top mental health resources that have many more offerings than other centers, and it just happens to be my postcode that's affecting that. So it's incredibly difficult. There are advocacy groups that have strong views about people with a mental health issue going through MAID. Given that a lot of people do suffer mental disorders, again, we can't make blanket statements. And I would say, if we're guided by our humanity, compassion, and understanding with as good as possible an ethical framework guided by good clinical practice as well, anyone who's sat, personal opinion now, anyone who's sat with a person in a terminal stage of illness or going through severe suffering through their disorder, and the person's requesting to rest, sometimes the compassionate, understanding thing to do is to support them to have as good a dignified death as possible. Maybe not all my colleagues agree. I mean, I don't expect 100% agreements, but there are moments in end of life, the dignity, peace, and comfort go a long way. I've been there with family, I understand that.
Thank you, and thank you for sharing that. So the next question, it's asking about the CASMIP initiative that you mentioned. It sounds like a great opportunity for collaboration. So can you tell us more about this organization, its goals, and how can someone join and who could join?
Yeah, so it's work in progress, and maybe it's not a huge structure, but it's a collection, and whoever it is could possibly email me. But really, it's an interdisciplinary group of people with a whole range of backgrounds: ethics, oncology, primary care, smoking cessation, psychiatry, nursing, to mention a few, who have a shared goal and objective to innovatively develop initiatives that will better support cancer awareness, engagement, screening processes, and so on. So I'd welcome an email around it. And it's everyone's business. I'm aware of other initiatives in other places. In the space of healthcare, this is more implementation science. So this isn't just, oh, we've got good guidelines that do this. Yeah, we read that. How do you do that in the real world? How does a person who has just left clinic get home? Do they have food? If they're thrown up, who's there with them? If they're in pain, what do you do? If you've got a pump on, and so on. So I hope your center here would also be perhaps a key hub for many like-minded people doing pockets of work in different places where we can set up a much larger community. There'll never be a shortage of people with severe mental illness. There'll never be a shortage of people with cancer. And I think collaborating into maybe a sort of cancer and severe mental illness network would be an opportunity to scale up the work we do. We can build a community.
Great, thank you. I don't see any other questions, but I'm going to ask one just in case anyone has any that they want to throw in. And it's along the lines of what you were suggesting about creating a community. So for a lot of our colleagues here are probably working in institutional healthcare, in hospital settings. Not everyone, but I'm thinking if you could, I'm wondering if you could comment on the role of traditional institutional care. When you mentioned a colleague that goes out into the communities that met with an individual in a tent. If we know that follow-up to care is going to be a barrier, not having a home is going to be a barrier to proper cancer care. How are ways we ought to rethink traditional institutional care? How do we break down walls?
Great question. This may sound slightly controversial, but it really shouldn't be. All health structures are within communities, whether they're also. So hospitals are part of our community structures, as are schools, as are fire services, as are police stations. And for those of us who are practitioners in community mental health, everywhere in the community, the store, the barber, the hairdresser, and so on, they are opportunities to engage in shared knowledge and so on. I would say we know the larger population of people with mental health challenges and difficulties live within the community. We know that primary care physicians see more individuals with mental disorders than psychiatrists do. And I would say, strongly suggest we start building a strong community focus as well. When people are in hospital, the objective is to get them back home as quickly as possible. Does everyone have a home? Do they have homes that can support this? Are there children there or pets and so on? And a community focus that takes away from hospital-based care. Hospital-based care is fantastic, it serves a purpose, but people don't go there to stay. Well, some end of life. And I would say revisiting, just looking at the lens from the other end, whereby we are mobilizing every potential resource we have in the community. Everyone can play a role. You'd be amazed how much conversation on mental illness you can get going through barbering salons, through the barber. I piloted a program developed with our local taxi firm, and through small chit chats, the taxi drivers could be conduits for a lot of information. The hairdresser, schools, and so on. So we are community, and if I embrace the South African term, Ubuntu, I am because we are, then I'll strongly suggest that we make cancer and severe mental illness a collective community responsibility, so that no one walks alone.
Well, thank you, Dr. Deji, for your talk. Oh, and looks like another question has come in. That would have been a great way to kind of wrap it up. I love those words, very powerful. But here's another one. Any thoughts on the use of behavioral alerts on patient charts? Are they used excessively with mental health clients? How could they be used responsibly and in a way that plays to the strength of our patients? So this idea of flagging a patient's chart for negative behaviors, whatever those might be. And there's very often a wide scope of what constitutes what would raise a flag.
Yeah, one of the issues with behavioral alerts is, okay, they alert, but then what do you do? And knowing what to do when someone's going through behavioral disturbance can be a world of difference. For one person, it might just be giving them an opportunity to hold a teddy bear. Another person, they might just want to sort of write out how they feel. For another person, maybe music. And I would say, if I'm living with a severe mental illness, going through coercive care, just to remind all of us, a lot of people with severe mental illness are actually scared. So if a police officer turned up and a doctor and they already knew my name, but I didn't tell them my name, And then they're telling me, well, you're going to hospital, we're forming you. And I'm saying, but there's nothing wrong with it. And I'm scared. And I've got voices telling me they're about to kill you. And then I'm taken and put in the back of a truck, and I go somewhere else, and I get there, and there are alarms and things going off in Emerge. And I'm trying to run away because I'm scared I'm just about to be killed. And eventually I'm sedated. I end up on a psychiatric unit, and someone says, oh, hi, I'm Jesus. I think, huh? That's weird. Another person says, don't take the medication. They're trying to kill us. It's an experiment. It's very, very scary. And the fact that I'm agitated or trying to run away or uncomfortable in those situations requires a lot of sensitivity. So I'll say with behavioral alerts, the follow through needs to be what compassionate, understanding interventions can be put in place for the person. What are the antecedents? What are the things that trigger? Could it just be that every time I'm having lunch, Kevin keeps winding me up, and I don't like the fact that he's got glasses that have x-rays? Again, I'm not trying to label and stigmatize severe mental illness, but the world of psychosis where a person's struggling with the reality and reality testing oftentimes can be really scary. And if we bring that sort of compassion and understanding, perhaps we might be able to serve even through some of the alerts. Again, I'm not generalizing, but I've seen alerts where a person then gets restrained to forcefully receive medication. But the last time they were pinned down that way, they were raped. And of course they're going to fight. I mean, who wouldn't? So context matters more than the flag, and the compassion and meaning and time to actually find out why.
Thank you. Thank you very much for that answer. So I don't think anything else is sneaking in. So I'm going to pass it over to Jennifer to wrap us up today. But thank you very much for answering all of those questions. There were some challenging ones in there, and really appreciate your time and the answers.
Thank you.
Thanks so much, Kevin and Dr. Ayonrinde. Before I formally close, I just want to say I really appreciate, Dr. Ayonrinde, you giving voice and putting us in the first person perspective or experience of some of these people living with severe mental illness. I think, you know, the words that you've described and the experiences that you've described that they would have from their perspective is quite powerful, and really puts that perspective in our minds and allows us to appreciate it. So I really wanted to mention that. And then I think lots of us will be emailing you probably about how we can get involved in your SOS with your Cancer Severe Mental Illness project, because that sounds really incredible and kind of a way we can all contribute to some problem solving. So for formal closure, it's time to draw the lecture to a close. First, we would really like to thank Bill and Pat Harris and their family for providing our community with the opportunity to have these important and timely discussions about ethical issues that impact cancer care in memory of their incredible daughter, Pippa. We would also like to thank our speaker, Dr. Ayonrinde, for directing our attention to the syndemic challenges in accessing cancer care for those experiencing severe mental illness. His research and advocacy not only deepens our understanding and recognition of the interplay of lifestyle and illness characteristics, along with ethical, systemic, and stigma barriers to equitable cancer care experienced by this population, but significantly identifies a call to action to address these barriers in healthcare systems and clinical practice. This topic couldn't be more relevant today as our global community's physical and mental health are challenged significantly as tragic events are unfolding around us that include much pain and suffering. We hope that today's discussion will contribute to further collaboration and collective action aimed at interdisciplinary problem solving to address the devastating effects of systemic and syndemic barriers to health and well-being within our healthcare system and beyond. And with that, I thank you and have a good afternoon, everyone. Thanks for attending.